How are we going to evaluate a transudate? So if it is no permeability, it is going to be a transudate. So if it is a transudate, so it is non-protein rich fluid. Non-protein rich fluid. So this is how we should think of it. Non-protein rich fluid. So we saw in the Starling's law, either there is increased hydrostatic pressure or there is a low oncotic pressure. So if there is a very low oncotic pressure, that means the protein in the fluid is very low. So this protein, so there are some endogenous substances which have a low protein by themselves. There are two things, which is CSF and urine. So if you have a CSF, it is called as a, so commonest cause for a CSF leak would be a uropleural fistula. Very rare, usually it is post-surgically you will see. Other thing, you can have a urine that is completely going to be having low amount of protein. So it is going to be having high creatinine and low protein. So that is what you're going to see in a urinothorax. So this is what is called as a urinothorax. So if you think, why is the urine going to come from the urinary bladder and from formation to the pleura? How can it come? So there are only two ways in which it can come. So if you say this is the abdominal cavity and this is a pelvis cavity. So either there is a urinary ascites. So if there is a urinary ascites, let's say there's a bladder rupture and there is a urine in the ascites, that can track into the pleural cavity. That can track into the pleural cavity. This is one way. Other way is something like a trapped lung, wherein there is a very high pressure in the lung and it just sucks the fluid. So then it is through the lymphatics it will go and drain into the pleura. So this is your urinothorax. How are you going to diagnose urinothorax? You take the pleural creatinine divided by serum creatinine. If the value is more than 1, it is going to confirm that it is urinothorax. So how are you going to treat the underlying cause? That's all. You do a drainage, you see why is it coming, and then you can treat it. Or what you can do is, if there is a diaphragmatic opening, so what you can do is a diaphragmatic repair. So this is how you will treat it. Either you can do a diaphragmatic repair or you drain it. If it is in the ascites, etc., you can drain. Next, exogenously, how can you get? There is a low protein fluid that you are giving from outside. How can you get? Let us say there is a central line that is communicating with the pleura. So inadvertently you hit the pleura there. So then it can happen. Or peritoneal dialysis fluid. Very common whenever you are having a dialysis patient. Very, very common this is.